Hey everyone, welcome to the Pregnancy After 40 podcast. We are going live today. As you all know, we are being joined by Dr. Ellen Wood. She is a fertility and IVF expert. So happy to have her here today. So we are a few minutes late. And I'm going to do my best on here. We're always technical issues, but we are going to work them out. So first, Dr. Wood, thank you for joining us today.
Well, thank you very much for inviting me, Michelle. I just, I have some strong thoughts on that differ from some fertility specialists on subject matter that your podcast covers. So I'm happy to share them with you and your listeners.
Sure, good. I know a lot of the members have questions. As you know, this is a pregnancy after 40 group. So this is the age that a lot of women kind of get nervous about their ability to even conceive or have children. So knowing that IVF is an option, or a lot of the other options as well, not just IVF, but you have experience in a lot of that. So first question is what all women want to know. And that is, what is the age of the oldest woman or women that you've actually helped to conceive in your practice?
Okay, so as far as I'm concerned, so most patients who come to us, okay, are clearly having problems. So we see a completely different type of patient. So where we can't say that patients who are in their 40s can't conceive, the ones who come to us have already had issues. So using ART, which is assisted reproductive technologies, I have one 44-year-old who used her own eggs. And I have about 5 43-year-olds that have been pregnant. This is 20 years. Okay. However, they were already patients who were having difficulties. There's a different type of patient in their 40s, are the ones who are not having problems, and they are those who come to us and they have not been trying to get pregnant, but they don't have a partner, and they're interested in being single moms, and they're using donor sperm. So when we are talking about that type of patient, the oldest patient that I've helped have a live birth is 45, but again, she was not infertile technically. Then we help patients in our practice up to 48 and a half, 49, and those women in their 40s who are having babies, unfortunately, whereas they would love to use their own eggs, in most of those cases, it's just not physically possible. And so because of that, they want to have babies, and they've opted to use donor eggs. So donor eggs are a marvelous option for women who are in, their mid-40s, their late 40s, and our practice will help those patients conceive with donor eggs, which is insanely successful, up until the age of, we need to start the process at 48 and a half. We do have patients who have conceived after that. I have one patient who has 3 children. She began the process at 48 and a half. We didn't find her a donor until she was 49, but she was in the program. She conceived her first child, her daughter, at 49. She delivered, had a great pregnancy, delivered after 50, and then had extra embryos and wanted a sibling. So here she comes back 6 months after her C-section and says, hey, I want my other kids. You're kind of a little past our cutoff. And I said, well, how's your pregnancy? Pregnancy was perfect. We got her clearances medically and from high risk. And this was not anymore, but at the time, I replaced 2 embryos, which they weren't tested, which we're doing now a lot. And I replaced 2 embryos. She conceived with twins and delivered healthy twins. So after the age of 49, she's now, I think, 53 and 54 actually, and has her 3 little kids, and is just happy.
Wow, so, that is amazing.
Yeah. So there's like, again. So with IVF, again, my 44-year-old is my biggest success. It was her own eggs, and then it turns into there's different categories beyond that. So it's not just a one size fits all type of question.
Okay. So okay. How in so you said the oldest is around 44, 45. So
Mm-hmm.
when a woman comes in for I guess a consultation, is
Uh-huh.
what is the first thing that you suggest to her? So there's different options. There's IVF, there's IUI, there's egg donors, there's embryo donations. Do you offer those services first, or do you tell them maybe maybe you need to get a little bit healthier, clean your diet out? What do you suggest to them first?
Okay, so the way the initial consultation usually works is, number one, we need to figure out if the couple, okay, and we look at everybody as a couple usually if they're coming with their partner, and how long they've been trying to get pregnant, and what is the initial underlying cause of getting pregnant. So, is there an issue with the sperm? Is there a problem with the fallopian tubes? Is there a problem with ovulation? So instead of just saying, oh, you're not getting pregnant because you're 42, it may clearly be not them. We initially start off before we offer a treatment, we'll try to find out what the underlying cause is. And then once we have the underlying cause, that will really drive us into a direction as to what to do. Many times, however, we'll come up, we have normal sperm. We'll actually do hormone levels on the patient, and they're normal. So their egg quality test, which is done on the second or third day of a menstrual cycle, which is called an FSH, or follicle stimulating hormone. That test needs to be drawn at a specific time, and it also needs to be drawn with an estrogen level. And that test is going to be a reflection of the quality of an egg a woman has. It is a little more predictive in women in their 40s. I have seen women with abnormal FSH levels that are in their 30s, and it really hasn't affected our ability to conceive a healthy baby. It's a little bit more telling when you get into your 40s. Over certain levels, we use a cutoff of kind of 15. We start to see an incredibly high loss rate. So whereas we don't say patients can't get pregnant, if a patient has normal FSH, her chances of ovulating a healthy egg are going to be better if her FSH is lower. So we do worry, we just get like that, start off with that test. The other test that we like to get at our initial consultation is a test called an AMH. An AMH is going to be a snapshot of how many eggs a woman has left compared to other women her same age. We at least want the woman on the average for age, whatever it is, 41, 42, 43, and preferably we'd like her AMH to be above average. Because when you get and you start doing the treatments, essentially more eggs are going to mean more chances at conception. So the better your AMH, which stands for anti-Mullerian hormone, is, the better chances the patient is going to get lots of eggs. Lots of eggs mean lots of embryos when we're doing high-tech treatment. Now, in the lower tech treatment, it doesn't make as much of a difference, but in the higher tech treatment, we use it to predict how many eggs we're going to get. So the evaluation consists of checking out her husband, making sure he has sperm, checking out the woman's FSH for egg quality, checking out the AMH for egg quantity, and then evaluating her fallopian tubes. Now, this will give us a direction, okay, as to, is this an egg problem, sperm problem, and then I can talk to them about treatment. If there's nothing wrong, initially I usually like to offer improvement in ovulation using an oral fertility medicine, and then if the husband's sperm good, then we will try an IUI, or intrauterine insemination. Intrauterine insemination is a very low-tech type of treatment. Okay, but that's all patients need. They need a little push with their ovulation, they need a little extra sperm exposure, and many of them will get pregnant. Now, the monthly cycle rate, so the chances of getting pregnant in one of those cycles in a lady in their 40s is not great. I mean, we're talking 3-5%. So it's not great, but when you're looking at a couple who is coming in and say their percentage of getting pregnant is 0, because that's why they're there, 3 to 5% might not sound that bad. If that is unsuccessful, then I usually get more aggressive and talk to patients about IVF. Many times, IVF, because it is such a big undertaking, most patients are kind of afraid of it, and we have to kind of warm up to the idea that this is going to be your best chance of conceiving. So the reason it's your best chance of conceiving is because we're going to have the ability to use stronger medicine. Instead of the fertility pills, we're now going to be using fertility injections. Fertility injections are going to stimulate the ovaries to make more than one egg. So if I can get 10 to 15 eggs from a woman, and then I can fertilize them, and I can make 10 embryos, I can grow those embryos in the laboratory, and then in the laboratory, these embryos can get tested. This is the coolest thing that I think we've been doing in the last 3 years. Probably 85% of our patients are undergoing treatment like this. So what we do is once we grow the embryos, okay, they grow in the laboratory for 5, 6, 7 days after I perform an egg retrieval to remove the eggs. The embryos are grown to something that's called a blastocyst stage of development. At the blastocyst stage of the development, we have the unique ability to actually do a biopsy of the embryo. So an embryo consists of a baby part and a placenta part, and they should be a mirror image of each other. And so what we have this ability to do is actually tease cells off of the placenta, which is called the trophoblast. We then freeze the embryo, and then we will send those cells to the genetics lab. The genetics lab now takes 2 to 3 weeks to get results. The genetics lab will give us a report back and it'll tell us whether the embryo itself is healthy or not healthy. And this is the rate limiting step in all of our treatments, is the health of the egg and the health of the embryo. So once we get that report back and we know we have healthy embryos in a patient, whether she's 41, 42, 43, 44, it doesn't matter, she now has equal chance of getting pregnant with a 22-year-old once we know that embryo is normal. The difficulty is getting the normal embryo. So whereas 50% of the embryos are going to be normal in 20s, only 20% of your embryos are going to be normal at 41 and 42, and only 10% at 43 or less. So that's the challenge. That's the challenge. So if you're only 10% of your embryos are going to be normal, you need to make 10 embryos to have a chance of having one normal baby. And normally, I'd have to say on average, our patients in their 40s are making maybe 2 embryos to get tested, but 3 embryos get tested per try. Prior to recommending in vitro and while recommending the fertility medicine and insemination, okay, our practice, we kind of across the board will always look at lifestyle. So because we know that time is of the essence, because of a patient's age, we kind of like to do the lifestyle modification, lifestyle changes in conjunction with the evaluation, which while they're doing it, we can certainly, so if a patient comes to me and we see that her BMI is ideal, we'll mention to them, say, look, your success rates are going to be better if you lose 5% of your body fat. We have lifestyle coaches that work with us. We have nutritionists on staff that will do all of this counseling. So if we find a patient could benefit from this, we will we'll say, look, we're going to do your evaluation, but we also want you to be healthy during your pregnancy. So we don't do one or the other. We kind of do both together.
Okay. So a question that I have personally. So I know a lot of times when we're trying to conceive or when we're trying to conceive, not able to get it, the issue is with them and it's with their eggs. How often do you see that it's the actual the male sperm that may be an issue? Is that ever an issue, or how often is that an issue when you have women come into your office?
It is an issue about 40% of the time. It's
Wow.
It's been, yeah, no, it's crazy. I started my fellowship in 1997, and at that time, male factor infertility was 8% of our business. 80% was female tubes, ovulation, endometriosis, polycystic ovaries, things like that. That was the bulk of our practice. And over the last 20 years, I've been with IVFMD in Broward County for 20 years now, and it has been just shocking that the amount of male factor that we are currently treating. So we have grown from 20% and now 40%, and it's growing. And it's growing. That's the cause of why the couple's having issues. Because male factor, if we can't find an underlying cause, it's very, we only have 2 treatments. So the one treatment, and so the way I break out the sperm, so this is how I kind of explain patients. Sperm come in 3 categories. Okay, when we do an analysis, when we check the sperm, we're going to have normal sperm. Okay, great, guy doesn't have a problem. Then we're going to have borderline sperm. And the parameters on sperm that we're looking at is we're going to be looking at how many sperm you have. We're going to be looking at how fast they're moving. And then we're going to be looking at morphology. Morphology is the look of the sperm, normal head, neck, and tail, to make sure that that sperm is healthy enough to penetrate an egg. So we'll have borderline parameters. So we'll have guys, their sperm count isn't perfect, but it's not awful. Or their motility isn't perfect, but they're not super slow. Morphology, the look of the sperm, like they're not perfect, but they're not bad. So these are borderline. The borderline patients, the gentlemen, we offer them lower tech treatment. We will initially start with diet modification, weight loss, evaluating their medications, see whether that could be causing it. So we look for underlying causes first. If we can't identify any underlying causes, we will move forward with a treatment called IUI, or intrauterine insemination. And intrauterine inseminations are, again, a very simple, low-tech type of procedure, but they work. I mean, we don't have super-duper success rates with them, but we don't super duper crazy success rates with IUI. But again, it takes you up to, especially in women under the age of 40, it can take you up to 10 to 15% if that's the reason. It's not, again, as I said, 3 to 5%. It's not that successful in ladies over 40, but it still is a step above zero. So we usually do like to try that with the guy who's a borderline parameter. And then the gentleman with poor sperm, again, we evaluate for underlying cause, see if we can fix it, and if we can't seem to get the sperm count up or identify what's causing it, then the only option that patients with poor sperm have is to do IVF and proceed with a procedure called ICSI, or ICSI, which stands for intracytoplasmic sperm injection. And that is a technique where my embryologist will take one egg and they'll take one sperm and they will inject the sperm directly into the egg with a glass needle. As we've been doing that in IVF world since 1993, it was just when we got the report out of Belgium that said that you could actually inject the sperm into the egg, it was earth shaking in the IVF world. It was never heard of before that. The only option for gentlemen with the poor sperm count was donor sperm. Before some Andre Spercam, a Belgian physician or embryologist, came up with this technique, and it's been used widely ever since. And I think it's used in the majority of IVF practices and in the world. Most of our eggs are now fertilized in the lab with this ICSI technique.
Okay. So IVF itself and just the different options that you have seems like such a huge undertaking and a lot just for a woman when she's trying to get pregnant. And so, we as women, we try to do what we can before we consult an expert such as yourself. So before someone walks into your office, if, to all the listeners out there, what would you suggest that they do before they actually walk into your office in order to maximize their chances of conceiving?
Get healthy. Basically, you have to, there's certain things that we find to have clearly negative impact on fertility. Okay, so too much caffeine. Okay, too much caffeine can cause vasoconstriction of your blood vessels, can cause poor blood flow to the uterus and ovaries. That's something that's controllable. We found that one caffeinated beverage a day really doesn't make a huge difference, but I've seen patients that are drinking 8 to 10 cups of coffee a day. I've seen patients, I had one lady who didn't know she was diabetic, and she was drinking 8 cans of Coke a day. She came back with full-blown diabetes. So we like to look at, and some gynecologists do, but again, lots of women miss this preconception visit. So we talk about preconception health in our patients. So it would be, don't have to see a fertility specialist, see your gynecologist, make sure your thyroid's functioning well, make sure your prolactin's functioning well, make sure you're not diabetic, make sure your blood pressure is good. The healthier you are beforehand, the healthier baby. So just everybody knows what they need to do to be healthy. You want to be an ideal weight. You want to be eating a healthy diet. You want to be exercising 4 to 5 times a week. You want to be moderating alcohol. We don't say no alcohol, but limit the alcohol to maybe 2, at the most 3 drinks in a week's time. Anything in excess when we're talking about fertility is bad. Okay, so anybody who's exercising, more than 30 minutes, 4 to 5 times a week might be compromising their ability to ovulate well. And again, if
Wow.
anybody is drinking more caffeine, maybe compromising their blood flow to the uterus and ovaries. I mean, there's certain people that are drinking excessively could be lowering their chances of getting pregnant. Marijuana is a big one. Stop smoking pot. Stop vaping. Oh my God! Like I mean, people tell you this, and you're thinking, isn't this obvious? But let me get on my soapbox about smoking. Okay, nicotine is one of the worst things that a patient, more for the woman than the man, but the woman is affected by the man's secondhand smoke. Nicotine is one of the worst things for fertility. And if people walk into my office and they are smoking tobacco, they get my lecture, okay? I say, look, I had a young lady, she drove down to Orlando to do infertility with us, to do IVF with us a couple of years ago. She was 40 years old, her tubes were tied, and she was a smoker. And I said, if you can't quit smoking, you can't do IVF. I said, just throw your $20,000 out the window on your way back to Orlando. There's 3 things that a woman can do, okay, to really alter your God-given supply of eggs. Women, we are born with as many eggs as you're ever going to have, okay? You're genetically predetermined. They're just going to die off at a genetically predetermined pace. However, there's 3 things that can happen to you that can make those eggs die faster. Number 1, have surgery. Okay? So you have a cyst. All right, there's nothing you can do about it. The cyst isn't going away. It's getting bigger. It's causing pain. It's twisting. Okay, yes, you have to have your cyst removed surgically. There's no other way to get rid of the cyst. When you do any surgery on the ovary, you're going to deplete egg supply. But, that's out of your hands. The other thing is chemotherapy. 60% of women who undergo chemotherapy for breast cancer, and we are seeing breast cancer more and more and more in younger women, but 60% of women will come out after their chemo menopausal. Chemo kills cancer, chemo kills eggs. Okay? Again, out of your control. Okay? Things that are equivalent to those 2 things, nicotine. Okay? Nicotine is a direct egg toxin. Patients who smoke during an IVF treatment cycle have the success of the non-smokers. Okay? Women, 20-year pack-a-day history of smoking. Okay? Average age of menopause in the United States is 51. Average age for pack-a-day 20-year smokers 46. You go into menopause, say 5 to 6 years earlier than you would if you weren't smoking. Okay? So you are depleting your God-given egg supply every cigarette you smoke. Secondhand smoke has the same effect, which is terrible because if your husband smokes, you can't be around. Not even know whether you just smell in the clothes can affect your eggs. I have one poor patient right now that she has unfortunately been around secondhand smoke for her entire life because she works as a floor manager in a casino. Her poor egg supply number is so poor. It's terrible. It was not her fault. Like it's her job. But I really feel that those numbers are so low. She's almost 39 and a half, almost 40, because of the exposure to the secondhand smoke. So if I have to say the number 1 thing, stop smoking. Marijuana is something that we don't know a lot about, but when I look at it, I think, all right, so tobacco is smoking a plant, marijuana is smoking a plant. So I don't know, we won't know for a long time what the long-term effects on people's fertility is, but it just sounds like a bad idea. When you look at, when you watch old movies from the 50s, what show was he watching? The Crown, okay? Nobody thinks smoking is dangerous in those times. I mean, it's just cigarette after cigarette after cigarette. I mean, I did a lecture last year on lifestyle and fertility, and I put an ad in the lecture, and it was an ad of a doctor, okay, smoking, and it had, smoke the filtered cigarettes. They're healthy.
Right.
That was a cigarette company's ad. So again, we didn't know back then. So that's my thoughts on marijuana, is that, we just don't know. So since the jury's out, I can't imagine it being good for your fertility. So limit alcohol, absolutely stop smoking, vaping, marijuana, limit exercise. Low impact exercise is great. High impact exercise, not so great. High impact exercise has been shown to lead to lower pregnancy rates with IVF, higher miscarriage rate, more canceled cycles, things like that. The thought with high intensity exercise and excessive exercise, the feelings are that if you're exercising, yes, it's good for you, okay, but where's the blood going? The blood's going to your heart, the blood's going to your muscles, okay? The blood is not going to your ovaries, the blood is not going to your uterus, okay? It's basically a feel effect, and if you do this high intensity exercise chronically, day after day after day, the blood just forgets to where it needs to go, and it does not go back to the uterus and the ovaries. And what happens over time is just this feel effect, and the blood vessels just kind of start to shrink and wither, and you just don't get as much blood. And we see an enormous amount of patients who have been, lifelong chronic exercisers, just, for fitness, because their hearts are healthy, but their ovaries are in very poor shape. And this is where one of our recommendations is acupuncture. We are big proponents of acupuncture because I don't have any other tool to recommend to patients to try and reverse that process, try and get more blood going to the ovaries, other than trying to innervate the nerves in the pelvis. So I think acupuncture is a great tool, and a lot of our patients, they go to the acupuncture first. Don't come to me, they go to the acupuncturist. The acupuncturist, all right, I'm doing these great things for you. I think you need to see a fertility doctor now. So anything that can improve blood flow to the ovaries is certainly going to help. And all of these are just little teeny things. So moderate the exercise, moderate the alcohol. Again, if your body fat is too high, it can impair your ovulation. So all of these dietary lifestyle things, our focus should be on improving our body fat. So I don't know whether, you can get a body fat composition done. So you can be a good weight, but you can have too much body fat. So you want your muscle to fat ratio to be better. So this is where weight-bearing exercise comes in. And it doesn't have that feel effect on the ovaries. So there's all these just little things, just again, for health that will play into your fertility. But the whole kind of goal when you're trying to make yourself healthier is blood flow to that pelvic area, nutrition to that pelvic area. Diets that I like, a Mediterranean diet is one of my favorites because when they've looked at patients going through high-tech fertility treatment and what diet has been the best, there's not really one clear cut, but the Mediterranean diet always comes out on top. So avocado, lots of colorful vegetables, fish a couple times a week. I mean, there's so many different, things like that. Try to avoid, and again, food, forget it. If because people will say, oh, this protein bar is healthy, and they'll kind of turn it over and look at the label, and it's just all sorts of weird words on there. And it's like, no, just eat real. I mean, honestly, it's pretty simple. Eat real food. But eat real food. I prefer organic if people can afford it. I do think that the pesticides and the fertilizers out there may be keeping my business going. I mean, I do think that glyphosate that's in the Roundup that's leached into the entire food system is one of the reasons that my sperm counts are declining. I think it may be why egg counts are declining too. So I'm a big proponent of meats with no hormones, grass-fed beef, if people are meat eaters, fish, chicken, but I like the organic, no hormones and pesticides. It just makes sense. So these are all things that will benefit your health as well as your fertility.
Right. Okay. So I know those are the things that you suggest for the women. How important are those things as far as the alcohol, the exercise, and you already spoke about the smoking? How important is that for the partner or the male to abstain from those things as well?
Oh my gosh. If the gentleman has a normal sperm count, it's a hard argument to make. Okay. However, if he has any problems, whether it's with count, motility, or morphology in the sperm, okay, these lifestyle changes have to be adopted by both partners. Absolutely, they are critical to success. So we do, if I have to tell the woman smokes and the guy smokes, I said, look, you got to quit with it. This is something that is but weight for gentlemen, I mean, is also critical, because if a guy carries too much body fat, okay, his body fat is going to be making excess estrogen. Excess estrogen is going to lower his sperm count. So this is, weight for gentlemen is also incredibly important. And we do try to optimize patients as couples if they're both committed to the process. then we give the same recommendations to the gentleman as we do for the wife. I've seen gentlemen who consume too much alcohol, and it shows in their sperm. And it's really, really interesting how lifestyle modifications for gentlemen can make huge difference. The thing with guys is that we get some short-term gratification from it, because if a gentleman makes a change, okay, I can see the change in 3 months. We're still there. Sorry. Oh no.
Okay, we went out for a
sorry.
minute.
Sorry.
Okay, so the last thing I heard was, if a gentleman makes a change, you can see the results in 3 months. And
3 months, yeah. So it takes 72 to 90 days to make sperm. Okay. So with 72 to 90 days to make a sperm, it's kind of like, yeah, the guy starts taking vitamins. He stops getting in the hot tub. He doesn't use his sauna, and all of a sudden, sperm count that was suppressed, sperm that were low. 90 days later, we're like, oh wow, you've doubled your sperm count. Oh my gosh, your fertility went from 20% to 60%. Like, it's like, wow. Okay, great. So sperm, we can see a change in just that 3 month period of time, because the sperm are just constantly being produced. So at least we get some positive feedback for gentlemen. With women, it's we can't really see it as much in the eggs. I do see it. It usually takes 3 months. Once I tell a patient who I believe is excessively exercising, it does take about 3 months to improve the blood flow back into her ovaries and to get her ovaries to respond good to medicine. So it is a 2 to 3 month period of time that we can make any of these changes, but it's just easier if you die.
Okay. So I know that, or going through your bio, that one of your concentrations is, let me see if I'm saying this right, congenital uterine anomalies, correct? As one of your specialties or concentrations. Can you tell us what those are and how those are treated as well?
Okay, so basically when the uterus forms, okay, it comes from 2 tubes in the system, and these 2 tubes have to form, and they have to cannulate in order so the uterus can form in a nice triangle, okay? Many times, because again, one of the parts of the system comes from one side, and this is when you're in utero. So these 2 things have to form, and there's a piece of tissue in the middle of the uterus, and it has to basically get reabsorbed in order to make the uterus a triangle. So many times that doesn't happen. These anomalies maybe happen in 5 to 10% of the population. Some of them are associated with infertility, and some of them are not. Now, the most common uterine anomaly, and the one that I specialize in and I'm repairing, is something called a uterine septum. A uterine septum is when there's a piece of tissue in the middle of the uterus. That piece of tissue does not have blood supply to it. So if your embryo implants on a uterine septum, which is in the middle of your uterus, okay, and it starts to grow, the embryo starts to grow, it basically, by the time it hits about 7 weeks, there's no blood. Like the embryo basically, it runs out of blood, the heart stops, and the patient miscarries, unfortunately. Not everybody miscarries that has a uterine septum. There are women who have had babies. I just saw one the other day. She has a baby, successful baby, and when the doctor did her C-section, the doctor told her, you have this extra piece of tissue inside your uterus. I think you should go see the fertility specialist after you recover from the C-section. So I saw her, and her history consisted of, she had 1 miscarriage, then she had her child, and she wants another child. So she said to me, well, what should I do? I said, well, you tend to have a healthy child, but if you want to lower your chances of having another miscarriage, it would be best to have a surgery and to remove this septum. Removing the septum is a 10-minute surgery, and it can be very, very quick, very, very easy, low complication rate, and it can just improve fertility. It's not necessary, but if you are doing fertility treatment, we usually recommend removal. You can have a healthy birth with a septum, but your miscarriage rate is higher. I had one patient years ago who had 9 miscarriages before she was diagnosed with a septum. I did a 10-minute surgery, her 10th pregnancy. She was getting pregnant very easily. Her 10th pregnancy was good. I know, no, just she wasn't evaluated by a fertility specialist. It was an ultrasound tech. I think there's something wrong with your uterus with her last miscarriage, and then she sent to me and we fixed it. But I just did a septum, like on Monday I did a septum. But that's the anomaly that we fix the most. The other anomalies can be your what we call bicoordinate uterus, which is your heart-shaped uterus, where there's no tissue in the middle. It's just you've got one side here and one side here. And so that we really don't, unless a patient has a terrible, terrible reproductive history, we really don't reconstruct that uterus because there's no blood flow obstruction in either side. The problems that those patients will have is sometimes the baby's breech because the uterus is kind of cone shape. And so we see breech births, we see term births because we have one horn here and one horn here. The other type of anomaly is sometimes you have a duplicated uterus, what we call a didelphys. So you have you have two cervixes. So you've got a cervix over here and a cervix over here, and people have basically just two halves of the uterus with two cervixes. So when you get your pap smear, the doctor has to pap one side and pap the other. So it's two cervixes. Those ladies sometimes, and I also specialize in this, sometimes they have a piece of tissue right down the middle of their vagina. Okay, and so the way it's diagnosed is that the patient will come in, she's 16, 17 years old, and she puts in a tampon, and she's still bleeding. And so they put in two tampons because you've got two sides of your vagina. And that's also one of my specialty surgeries is that I remove that septum and make the vagina look completely normal. And even though when you put the speculum in to do a pap, you see two cervixes at the end. So they're the type of anomalies I repair. I've repaired multiple vaginal septums. A couple this year. We repair uterine septums. I've done a whole bunch this year. But the bicoordinate uterus, we really don't repair. The didelphys, we don't do anything with that as well. The other really weird anomalies are when you have just one horn and then the other piece of the uterus is not developed, and it's like the uterus here, and it's like stuck to it. It's like the uterus, and then there's like a little half a uterus here. We had a case like that 3 years ago, actually. And what happened was, I wish I had. Let me see if I have a picture here to kind of show you this, because it's kind of a normal uterus. And so what happened is this lady had a half a uterus, okay, and then she had like a horn on like this side, just a piece of uterus. So the sperm actually came in here, they went out the fallopian tube, they went in her other fallopian tube, and the pregnancy was in the horn. Now the horn wasn't connected to a cervix, so the baby had no way to get out. So it was the strangest case ever, but we had to terminate that pregnancy. And kill it because her uterus would have ruptured. So all sorts of weird stuff that can go on with the uterus, but the most common things we see are the septum. And they're the things that are, again, in my business, we electively remove them because patients are doing fertility treatment. But in the regular world, lots of patients walk around with these anomalies and don't know they had them until they come and seek out fertility help.
Okay. You're telling me like things I've never even heard of, thought of, or even imagine even now, even after you explain it.
This is my world, is easy.
So, okay. So in one of our initial correspondences, you stated that you are a realist, but you're also an optimist. So what did you mean by that regarding fertility and what you do and what you specialize in?
Well, what I see a lot when patients come to us is, and we do a lot of second opinions, okay? And a lot of doctors, I think, and I think it's very short-sighted. I think a lot of doctors will look at your hormone level on paper, okay? They'll look at your AMH level, they'll look at your FSH level, and they'll say, this treatment's not going to work, you need a donor egg. I mean, the patient never got the chance to even try even a fertility pill, let alone wasn't even offered a try at IVF, and the doctor just looks at their hormones on paper and said, this will never work. I'm like, how can you say that? I never understood how you can just look at paper and treat a patient that way. I mean, I have always practiced, I treat patients, not paper. I use the paper to explain why something didn't go well, or why this might have worked, or doctor, why didn't I respond to the fertility medicine? Well, your FSH is kind of high and you don't really have very many eggs. But the amount of patients who I personally have helped, and they have live, healthy babies, and they're levels on paper are just, I gotta say, god awful. Like, you give them a try. Like, I don't think you can just say, oh no, you know, your hormone level is this isn't gonna work. I mean, I have a patient, like, the AMH test, the lowest you can get is like 0.03, like the lowest you can get, okay? I had a patient, she was 42 when she kind of started, and we did multiple different cycles, and some of them were disastrous. I mean, you know, we would get 3 eggs, and then they wouldn't fertilize, and they would die, and she's just like, no, I'm having a baby. No, I'm having a baby. I mean, so I kept designing different types of treatments, different types of protocols, different recommendations, okay? We hit it on the 5th try. This lady with these terrible hormone levels that it just looked impossible for her to ever have, you know, her own genetic baby, worked. I mean, it just blows my mind. And I say to myself, wow, if I had just said to her and blown her off and say, you know what, your hormone levels are terrible, like, you know, you need a donor egg, that's going to work better, she wouldn't have a baby. And over the years, I've had so many patients who I think that I don't know whether it's just doctors haven't seen it happen, which is why they don't offer it, or they just, you know, they don't want to try to, you know, they don't want something to fail because it affects obviously our statistics. You know, we have failed cycles, all our cycles reported to the CDC and to start, you know, the Society for Assisted Reproduction. So, but I don't think that I should try and, you know, beef up my own statistics and not give that patient a try. So, I had a patient, you know, years ago also that, you know, she comes and her FSH level was just terrible, just terrible. And she's, you know, sits in front of me and it was all of her levels had been okay up to this point. And she comes to me and we're ready to start an IVF treatment. And she's like, Doc, you know, what does this mean? And I said, well, it's not good. I said, it's not good. I said, remember when I said we might get 10 or 15 eggs? I said, I'm taking that back. I said, now I'm going to be happy with 3. Okay, if we get 3 eggs, we'll be good. I said, there just has to be 1 healthy egg. So, you know, and she's crying. She goes, well, should I just go with donor egg? And I kind of looked at her and I'm like, if you want to, but let's try you first. And if you fail, then we can discuss donor. But I'm going to treat you. I'm not going to treat your FSH of 25. And we stimulated her. We got 3 eggs, 2 fertilized, 1 baby girl. Like, but if you talk to, I would have to say maybe 8 out of 10 fertility specialists, they would look at FSH in somebody who's 40 or 41 of 25 and just say, like, there's no way in heck this is ever going to work, so let's just not do it. I mean, if patient is stimulated, we're getting eggs and it doesn't work and we try to do it again and it's financially feasible for them to do it again, we're going to, you know, we can get success, but sometimes there's only some cases, people can only take so much financially, people can only take so much emotionally. So at that point, we have to look at it and say, all right, you know, you've tried this 3 times, we're not successful, you know, you're getting emotionally worn down. My goal is to help you have a baby. Okay, now I'm going to direct you the donor route. This is probably going to be a more successful thing to you. But you have those patients who, you know, they are just strong. I mean, they are just strong, and if they have the, you know, means to just give it, you know, that one last try, will be successful. Even just to give it the first try. I've seen patients where they shouldn't even do it 1 time. And I thought, well, that just, I don't know. It's me. It's something personal for me, because if I was in my 40s and I wanted to try, I don't really care what the paper says. You know, like, show me. Show me if I try this, it doesn't work. And it doesn't work. All right, well, the paper was right. Okay, the numbers on the paper were right, but the number on the paper might be wrong. So that's where I'm at. Actually, I've seen crazy stuff happen that, according to the textbooks and the articles, like, shouldn't happen. And if we didn't do it, they wouldn't have that baby. And it goes over my mind, like, all the time. That, like, wow, if I hadn't, like, I had a lady with 2 kids now. I'm friends with her on Facebook, and she'd had a miscarriage before she came to me. We did IVF. She had her son. She was now approaching, 42, 43, that kind of age category. We did another IVF with her. She had another miscarriage, and she's approaching 43. And I said, look, you've already 2 miscarriages. You know, you have your son. You might want to think about donor. And she's like, Dr. Well, please, can I try one more time? And I said, all right. I said, it may not be a great idea. Let's try. Baby girl, healthy. You know,
Wow.
I mean, and I was even a little pessimistic. Like I was a little pessimistic about trying, and she's the one who kind of begged me, and I'm like, I said, okay, you know, if you're emotionally can handle the treatment, because it's hard. It's really hard going through these treatments. I said, and financially, this is not going to break you. Let's try. I came down here. I've been in Florida for 20 years, and my first year here, I got told something by a doctor in the physician lounge that has just stuck with me ever since. So this lady was a pediatrician, and you know, I'm a bright. I was 1 year out. I was like 1 year out of fellowship. You know, so you know, we're very academic, and it was like bright and perky, blah blah. So they introduced this pediatrician to me. I was meeting different doctors in the hospital, and she goes, oh, I had my twins with IVF at 43 or 44. She said, I'm like, oh gosh, wow, and I don't know. I blurted out, which is inappropriate at the time. I'm like, oh, did you use donor eggs? And I'm like, it's not this lady.
Wow.
I'm like, oh, I shouldn't have said that. And she goes, no, sit down. And she was older. I was 32, I guess, at the time. And she was like, obviously 46. She's like, sit down. I'm going to teach you something. I'm going to teach you this. I'm like, okay. And she goes, look, let me tell you my story. So she goes to tell me she had done with our competing practice down here. She had 3 IVF treatments. Okay, and this was back in the day where we put embryos back in, not blastocysts. We did it completely different. It's still the same idea. Stimulate the ovaries, take out the eggs, fertilize them with the sperm, and then put the embryos back. So she had done 3 failed IVF treatments, and she begged the doctors there to do the 4th treatment with her. Okay, she said her doctor walked into the room, okay, the day of the embryo transfer, and said to her, I can't believe, Rachel, you're doing this. This is the stupidest thing. You need to stop. And she looked at him and she goes, look, just put my embryos in. Okay? Twins. Like 43.
Wow.
Like, she goes, look. And she looked at me and she goes, this is the lesson. Never say that to your patient. I was like, okay. I mean, you don't have, but yeah, I mean, I didn't have the experience at the time. I'd only been doing this for 3 years, you know, and the practice that I came from in Philadelphia where I did all my training, we were that like, FSH is over 14. I think that was the cutoff at the time. We wouldn't even do you. Like, you couldn't even come through the program. You couldn't even try. If you're, I had a lady who, and FSH values, like we had this cutoff to the point where the competing practice in New Jersey would put ads in the newspaper that would say, we'll do FSH.
Wow.
Because we had this cutoff that you couldn't come through. And then, so this is where I had trained. And so kind of I moved to Florida, and that was in my mindset. And then I start looking at the docs I'm working with, and I start looking at the charts, and it wasn't that busy. So I'm looking at the other doctors' practices, and I'm like, oh my goodness, this lady's FSH was 29. She's pregnant, healthy. Okay, I've never seen that before. And I started just looking at what other people, other than the ones I had trained with, you know, had done, and I was like, not supposed to happen. I was told that to happen. And some of the physicians in our practice just say, well, what's the harm in trying? Like, let's give it a try. What's the worst thing that could happen? I mean, yeah, we know donor egg is the best, but if the patient wants to try, let's try. And I started to see, you know, these other physicians that I was working with. I'm thinking, well, okay, well, why don't I try that too? So I started like kind of pushing the envelope a little bit, and then like, I'm like, I'm really getting into, you know, it wasn't, I mean, the success rates aren't great, but it's a matter of having your own baby versus using a donor. And that's where we kind of, I just personally, that's where I said, you know, I'm realistic, like, hey, these hormone levels aren't great, but I'm still optimistic as far as let's give it a try, because what's the worst thing that could happen? It doesn't work, okay? And what's the best thing that could happen? It could work, because I've seen all this crazy stuff happen, and it's like, and I just really, I think my head, well, that shouldn't have happened, but it did. She has a baby girl, like, we had a baby boy. I'm like, wow, that's just amazing. So it's really, there's more to the type of medicine I practice than just like following algorithms and giving everybody, a donor egg if your hormone levels don't fit the mold.
Mhm.
But I'm a
Okay,
little
so
that's good. Trust me, there's lots of my practice you completely disagree.
well, that's great. I mean, that's really encouraging to know that, you'll try different things. You just won't look at numbers and say no and reject someone. So speaking of donor eggs, though, there are differing views on donor eggs. In my mind, I know there's competing views. So in my mind, I'm like, okay, if I had to go that route and I birthed the baby, I carried a baby and had this baby, like this is my baby. Um, how do you reconcile that, or how do you explain that to other women who are thinking about donor eggs, but they have this reluctancy in doing so? What is your position on donor eggs and genetics and all of that?
I think donor eggs are great. Again, I'm in the family making business. Okay, I'm in the baby business, so we're trying to help patients have families. And if we come to the conclusion that it's not going to happen with their own egg, it's something that the couple can do together. So basically, what the couple can do together is they choose the egg. Okay, so the man plays a role. He gives the sperm. The woman plays a role. She carries the baby. They choose the egg together. Okay.
Mm-hmm.
Giving up on your own eggs, there's 5 stages of grieving, okay? And you do have to come to the acceptance point there. I want to have a family and baby with my husband, okay? And in order to do that, I'm going to have to give up the dream of, yes, the baby looking just like me, okay? Even though you'd be amazed how many people look alike. There's doppelgangers out there. So
Right.
it really, sometimes when you see the baby, like there's no idea. You wouldn't know. And so I just have to tell you from a personal perspective, when I was pregnant with my first daughter, okay, I thought about this all the time. I thought about, oh my gosh, I'm carrying this baby. She's moving around inside me. Like, how would I feel if I knew it wasn't my egg? Okay. Now, I had expected my child to come out bald, blonde, okay, just like looking like my sister's 4 children. My sister had 4 girls at the time, and they all came out like bald, blonde, like light-skinned, fair-haired, okay? So here I give birth to this child, okay? She comes out. I look at her and I go, oh my God, there's no way that could have been my egg. I mean, this cat had a full head of dark hair. She had olive skin, okay? I mean, her father's Lebanese and Italian, so I don't know why I didn't expect that. But anyway, I'm like, if you told me that wasn't my egg, I completely believe you. I mean, because the kid looked nothing like me at all, like not one of my features. And she slowly grew into be a Lebanese, Italian-looking kid with freckles. So, I mean, there might be a little bit of me in her, but, I don't think it would matter one bit. So we use donor eggs all the time. They complete families. They make families. We use frozen eggs and fresh eggs. And I think it's something that is great. What I think the future holds as far as donor eggs is concerned is be your own donor. Okay? Be your own donor. So save your eggs at 25. If you want to wait till 47 to have a baby, use your own eggs. I mean, obviously 47-year-olds now don't have that option, okay? But be your own donor. So both my children, they're going to grad school, okay? I told them, I go, look, I said, mommy's freezing your eggs by the time you're 25, okay? If you don't use them, great, you can sell them to an egg bank. If you don't want to have kids until you're in your 40s, okay, and you don't get pregnant, okay, you've got 25-year-old eggs frozen for you, and you be your own donor. So in my opinion, if somebody knows they want to delay childbearing, and we just know that age is their biggest factor with childbearing, that, if you freeze your own eggs, you can be your own egg donor. If there's a country, some singer out there that actually did that, had babies in her 40s, and they were embryos that she froze in her 30s. They were egg freezing was big when she used them, but they were embryos. So, we use fresh eggs, we use frozen eggs, we use known donor eggs, we use nieces, sisters. I mean, it's whatever you're comfortable with. But I think at the end of the day, the goal is family. The goal is having a child and family. And sometimes you have to give up that, that actual genetics. But I don't think, we've never had anybody come to return one of their babies, like saying, no, this isn't what we ordered. And so I think donor egg for women who have just, not been able to conceive with their own eggs is a fantastic option. What other questions do you have on that?
That's it for donor eggs. I'm going to wrap it up soon. But we did have one question earlier on where someone asked, what do you recommend for those of us who want to do IVF, but insurance doesn't cover it and we can't afford the $12,000? So it looks like there are some options, financing options, that you all also have a raffle, I believe. Do you know much about that as far as the raffle to get a free
Yes.
IVF session?
Yeah, we give away one every 6 months.
Really?
And people have to, yeah, we really do, and we really do. We really do. Every 6 months, it's like the financial people. It's not, and it's random. I have a patient actually on the wall today that she had twins from me years ago. She actually had a unicorn uterus, a happy uterus, and I shouldn't have got her pregnant with twins anyway. They're both healthy though. Anyway, she won the raffle. I'm like, she's won a raffle. But the doctors don't have any say in who wins the raffle, so it's just like they pick a random name, and then the patient will show up, and I say, oh, so what? She goes, oh, bring yourself my IVF. I won your raffle. I'm like, oh, cool. So it's been different tactics, but we know we really do give away an IVF cycle every 6 months.
So how can a person actually get in on the free IVF treatment? What do they have to do?
You enter the raffle on the website, I believe, on the www.ivfmd.com. Yeah, it's an entry website.
Okay, and do you know if there are any restrictions?
You enter the raffle, and I think then.
Go ahead.
I really don't know. I think there would be probably a box on the website that'll say something, something about it. But trust me, I've had, over the years that we've been doing it, I know 2 of my patients had won the raffle, but I didn't know. Sometimes our social media person Shirley, sometimes she'll put it on our Instagram, like raffle winner was Michelle P, or something like that.
That's awesome. That's awesome.
It's not a hoax. It's not a hoax. It's not a hoax. You really do it.
So there is hope.
And what we also have, yeah, there is hope, but I think there's financing options. We have at least 4 or 5 different financing companies who finance, all of our IVF treatments. And we're seeing more and more insurance coverage just by the employer, buying the insurance coverage. But I know our practice at IVFMD, we offer a wealth of different options for financing.
That's awesome. Well, thank you so much. I know we've been on here for an hour and you've given us a lot of information, a lot of things to talk about. So I just want to thank you again for sharing your wealth of knowledge and information. And hopefully some of the listeners are in Florida or they're in the area and they will visit your office. Can you just give contact information?
Yeah. So, on our website is www.ivfmd.com. I have my own Facebook as Dr. Ellen Wood, and then I am on Instagram at Dr. Ellen Wood. As far as kind of following me, I try to put up, interesting content for patients, motivational stuff, and then I have my Facebook. But our offices now, this is the coolest thing. I'm telling you, there's been some goods and bads that have come out of this pandemic, okay? And one of the best things that come out of this pandemic is the ability to get paid by insurance for virtual consults, okay? So we do second opinions from all over the country. We give patients, we look at records. We'll have patients, if we want to do treatment in our lab, because our lab is the best in the state of Florida, one of the best in the country. Patients want to do treatment with us. They can come down for 2 weeks and do treatment with us. But we can meet the patient virtually before they even come and come down and talk to us. So they don't have to fly in and see us. They can meet us on the computer. We send them all the information, answer all their questions, and then they can decide whether they want to come to any of our 6 locations, because we've got 13 physicians in 6 different locations. We pretty much encompass the whole southern part of Florida. Our offices go from Vieira, Jupiter, Boca. I'm in the Cooper City office. We have an office in Miami and an office in Naples. So we cover the entire state. But all of our docs have virtual consultations. So even if you're out of state, you can hear what we have to offer.
And so I'm hoping that it actually continues after the pandemic. Being able to do things digitally and via video and teleconferences and all of that is just like amazing. It's helped out in so many industries. By day I'm an attorney, so it's helped that I do estate planning. So it's been great, like not having to leave, and it's just so much more convenient. It makes so much more sense, and it's
Yeah, no,
efficient.
we had been doing them before. So, I mean, I did consultations in Europe. I did consultations in California, all sorts of places. But so we had the whole setup. But the insurance wouldn't pay us for it. And now we're still getting reimbursed our same in-office rates according to our office managers. So that's what's nice, is they haven't taken it away yet. Hopefully it's here to stay. Because for patients, it's been very, very helpful. I mean, like, patients driving in the car talking to the fertility doctor. I'm like, oh, you pay attention to me, you ride the road. Like, or it's been very interesting where I've done these virtual consultations from, like what people are doing while they're talking to me.
Right. Well, thank you so much. I did catch your TikTok video as well on Instagram.
Oh yeah, I'm on TikTok. I'm on TikTok as well. Like that was something new the pandemic brought on, new talent. Dr. Wood learned on TikTok.
I have not been so bold, but kudos to you for doing that.
Let's go here. I have a 20-year-old and a 21-year-old. So
yeah,
this is their thing. Honestly, I never even was on TikTok before March. I never even heard of it.
Right. It's good
people
to have
just learned all these new things learned things from March on. So
that's awesome.
It's been an educational, interesting year. Let's go with.
Yeah, to say the least. Well, thank you so much for coming on here. If anyone else has any questions, you all know how to reach Dr. Wood, the website, or on her social media pages. We'll also leave the information on the show notes. And with that, thank you again for joining us, and you have a great evening.
All right. Great. Thank you so much, Michelle, for inviting me. I really enjoyed it. I can just talk and talk and talk.
Same here. You have lots of good information. Thank you, Dr. Wood. We'll talk to you soon.
All right, Michelle. Have a great night.
You too.
All right. Bye-bye.